Hello and good evening, friends. Today is the third talk in the master series of the ACNS webinars in the month of September. And we are blessed with the presence of the two of the most celebrated personalities in the world of neurosurgery. Ladies and gentlemen, I am honored to introduce you to today's chair and speaker. The speaker for today is Prof.Ahmed Ammar, who is a consultant neurosurgeon in KFHU Dawam University, Saudi Arabia. He is also the co-chairman of the WFNS Ethics Committee. Professor Ammar is a celebrated author and has published two most famous books in neurosurgery titled Ethics in Neurosurgery Practice and Hydrocephalus, What We Know and What We Still Do Not Know. According to Spring, this is the second most downloaded book, which amounts to about 25% of the large cache of books that Springer hosts. Professor Ammar is a noted researcher and has published more than 100 manuscripts in various international journals. He has been a guest speaker to more than 500 occasions in various countries. Today, Professor Ammar is going to talk about his favorite topic, ethical dilemmas in neurosurgery. To chair this session of Professor Ammar's talk, we are fortunate to have with us a very noted personality in world neurosurgery, Professor Franco Servadei, the president of WFNS. Professor Servadei was also president of the Italian Neurosurgical Society. He currently decorates the chair of Department of Neurosurgery, Humanitas University and Research Center, Milan, Italy. Professor Servadei is a noted researcher who has published more than 1,300 manuscripts in various international journals. As the chairman of the WFNS, he was instrumental in driving policies which benefited neurosurgeries in the low and middle income countries. His vision in neurosurgery saw it to that even the most remote places on earth had access to some form of neurosurgery. We are so grateful to have him to have accepted our invitation despite his busy commitments and chairing this session. On behalf of the Education Committee of the ACNS and the President, Professor Yevko, I hereby welcome today's speaker, Professor Ahmed Ammar and Professor Franco Servadei, to this online platform of ACNS webinars. Dr. Liu Bun Seng from Malaysia is my co-host for today. May I please remind our viewers that at the end of today's talk, there will be a small poll consisting of 3 questions which you have to answer. We will also ask you a question at the end of the webinar, which you will be answering by mailing us to our address acnswebinars@gmail.com. We will select 6 lucky winners, among whom one of the winners will get a hard copy of the book authored by Professor Ammar, which is titled Neurosurgical Ethics in Practice, Value-Based Medicine. Another 5 people will get a PDF of the copy mailed to their email address. Now it's time to start Professor Ammar's lecture. May I please hand over the proceedings to Professor Servadei?
Yes, there is not much to say. You have said everything. We are really, the ethical issues of our work are basically our daily life. Neurosurgery, it's important. As a large part of neurosurgery is dealing with emergency, and every day we face ethical dilemma about treatment, about management of our patients. Really have every day to discuss which are the indications, when we operate, when we don't operate, which patients are suitable for re-education, which patients are suitable for outpatient visits. And in this time of COVID, we have sometimes to restrict the access to neurosurgery, and the restriction is also based on a list of priority which crash every day again with our ethical problems. So please, Ahmed, present your large experience with ethical dilemma in neurosurgery, and then I hope there will be a nice discussion at the end. Ahmed?
Thank you, Franco. Thank you very much for the invitation and for introduction and to discuss such a very important issue, which I am really so much attached to it. I start by saying I have nothing to disclosure. Actually, I would like to add something. Franco and myself, we have been friends for over 40 years. And we shared a lot of good things together. We shared the aims, we shared the goals, and I enjoyed very much his friendship. So friendship is one of the good values, as honesty, as gratitude, as patience. These are universal good values. But are all the ethics and values are universal or not? This is very important questions. So the interpretations or the expression and the receiving of this value may vary between different groups of people due to different habit, different religion, different culture, different social, different circumstances. Bioethics is not an exception. The ethical root and the principle are universal. The ethical roots of bioethics, as we are going to discuss. However, the interpretation and implementation in the daily life may be slightly different in different things. The same thing, the people who wrote our teachers about ethics before, they were mainly philosophers. So there is different perspective if you read about the ethics. That is, there are researchers, mainly philosophers or bioethicists, but also the clinicians. They have the ethics in their daily practice or dilemma of ethics. And maybe the philosophers, they are out of touch. They don't know what we are doing. And we have also the deficient for understanding and analyzing which ethics we have to, ethical route we have to stuck to. Also the patients. Patients, they have their own beliefs, they have their own value. And this should be considered in our daily practice. What we did, medical ethics from bookshelves to the patient beds. Actually, as we said, traditionally, bioethics written and taught and discussed by great philosophers, ethicists. But when in common days, when there is the human rights and the patient right and the daily practice, everything was very difficult to be understood by the general practitioner or neurosurgeon or orthopedic. So it was a need that is to get these theories from bookshelves to the patient bed and make all these theories applicable and understood and digested. That is why we started to see new books coming up, written by neurosurgeons. First book, actually our book, The Neurosurgical Ethics in Practice, Value-Based Medicine, by Mark Bernstein and myself. That was the first book written by neurosurgeon, 2014. Then Marek Bruckmann, the chairwoman of the Ethics Committee of the European Society, she came up with her book, Ethics of Innovation in Neurosurgery, 2019. Then in another open access book about bioethics in neurology and psychiatry, I wrote a chapter about evidence-based medicine and value-based medicine. Lastly, a few weeks ago, a book came up by Steve Honeybull, the chairman of the ethics committee of WFNS, about neurosurgical ethics and neurosurgical practice. Also, I have 2 chapters in that book. So if we talk about the perspective of ethical implementation in the daily practice, first, ethical issue related to the patient. Decision-making, as Franco was talking. Which decision you make for which patient and at which time, which is suitable, could be suitable for someone, maybe it's not suitable for another one. The priority for admission, something like that simple. Priority for admission and the priority for surgery and life-saving. This is also an ethical question. Who you admit first? Because you would like operation, you operate, or you like this patient, or there are certain ethical guidelines to put the priorities for admission and surgery. The consent, as the patient has the right to consent and understand the consent. It's not only to sign, but to understand what he is signing for. Autonomy, patient rights, and the diversity of management. As we said, which method do you choose for which patient? But the thing is, which is also ethically important, our medical and especially neurosurgical practice is full of uncertainty. of especially when you especially talk about long outcome of this kind of procedure. So this has to be clear for the patient. There is no absolute one answer in most of the cases. Then if we talk about evidence, as we will discuss later, what is the ethics of evidence? And how ethical or not ethical an evidence could be. Then another also problem we face most of the time about holding or withdrawal medication or denying surgery or even braiders. All this ethical issue we face every day. But another ethical problem is ethical problem, professional approaches to the patient family and the quality of life, how it is in the balance, rehabilitation, the healthcare resources, and how can be justified to be distributed, injustice, research and innovation and inventions, medical litigation, career development, work environment, training and supervisions of programs, publication, work environment, good citizen of our planet beyond all borders, all these ethical issues. Okay, so we find many, actually the ethical implementation, it is fact in every step we do in our practice. But we would like to come to one language. We talk about value, but what is value? Is value a universal issue? Actually, it's not. Value is value when its value is valued. If this certain group values certain things, so this is a value for them. But this is why it is different from the ethics. And the value, even if this value is the same, but can be the interpretations can be different according to the angle you look at it. You can see it square, you can see it round, you can see it different, you can see it as you look at it. This is the influence of culture and background. So this is what we call it in ethics, in the science of ethics, ethical relativism, which means that is a theory which claims that because different societies have different ethical beliefs, there is no rational way of determining whether an action morally right or wrong. What's considered morally accepted or desirable in one culture, country, religion may be ethically acceptable or undesirable in another, but still it is a value for that group. We have to understand, before to understand the other, we have to understand ourselves. Medicine is not any job. We have to understand very well that we are privileged to have that duty to give care to the patient. We owe the patient everything. The patient, they don't owe us anything, just their health. Well, William Osler, I think all of you know, he is a great founder of the modern medicine. I quote him, he said, "We are here to add what we can to life, not to get what we can from life." He also said it is much more important to know what sort of a patient has a disease than what sort of disease patient has. He also said, the good physician treats the disease, but the great physician treats the patient who has the disease. And that is very important. And actually, if we look for around, we always indicate to the patient by disease, by anything, not by name, and this has an impact on us as well. So what is ethics? Is it what we believe? Or is it what we practice? Or is it what we understand and interpret? Or is it what we value? Is it the ethical behavior or ethical thoughts? Is it the individual ethics or it is group ethics? So the philosopher answered us, and they said, ethics is concerned with questions of moral issue. how people search for the right conduct means what is right and what's wrong, and how people are ought to act or are acting, so the action itself, or that act should bring good life and satisfaction, what we call it in ethics, consequentialism. So just to go not deep, but just to say what we are talking about in a few slides, there are three branches of ethics. One, what we call meta-ethics, which is mainly concerning about the nature of ethics, nature of the ethics theory itself. What does value, such as good or bad or right, wrong mean? What, if we say something good, what does it mean? Or are this judgment universal or relative, as we discussed before? Then, which is important, how can we know something is morally right or morally wrong? Is there a balance? Is there a way to measure? Then the second branch, what we call it normative ethics. And actually the bioethics is under this branch. Normative ethics is the study of what makes action right or wrong, what makes a situation or event good or bad, and what makes people virtuous or vicious. Normative ethics emphasize on three elements: the person who performs the act, then the act itself, then the consequences of the act. Then the third branch, what we call it applied ethics, is how is the ethics applied in our daily practice. It is belonging to it, actual value-based medicine is a part of it, and the code of ethics for medicine or others is part of it. Normative ethics theories, they are mainly three branches or subgroups. Virtual ethics, which goes back to the Greeks, Aristotle is the father of it. It focuses on the inherent character of a person. The virtues are identified as those habits and behavior that will allow a person to achieve a dominion. It means feel happy, have a good life. Deontology, it means the duty. Deontology is the approach to ethics that focus on the right and rightness and wrong of actions themselves. Under it come different types, law, traffic law, any law. Consequentialism or teleological ethics, it has a different approach. If I would like to say something is good, so I see the result of it. If the result is good, so that thing is good. If the result is bad, so that action is bad. There are many people have a lot of considerations or concern about it. Come back to our bioethics. When the emerge and the evolution of the principle of bioethics, in early years, thousands of years ago, it was referred as a humanized, the medicine or the practice of medicine was referred as the ethics in medicine, a humanized medicine. The cultures, values, ethical principles regulated and guarded by medical practice in all civilization. And actually, it was spiritual, and it was kind of gray in one way. So it is almost common between the Chinese, old medicine, Egyptian old medicine, Indian old medicine, and the others. All, they have the same principle. It's spiritual types of medicine. But our new medical ethics and bioethics evoluted actually goes to the Greeks. One of the father and founder of it, of course, is the Hippocrates. Hippocratic oath, which everyone knows, and I have a lot of questions and doubt if everyone really digests, or they consider it as a part of the graduation ceremony and get forgotten after that. He wrote in the Hippocratic oath, which everyone said it once at least in his life, I will prescribe regime for the good of my patients. according to my ability and judgment, and never do no harm. Look for the end of it to anyone, not only the patient. So the real good ethical doctor shouldn't do any harm to anyone. And also he said in another part, first, do no harm. This is another ethical issue. Then in 19th century, started that is the concept. There are, of course, during these 1,000 years, we find a lot of schools of medicine. We can talk about it in different lectures. That's from religious part of view, the Jewish, the Islamic, the Catholic, and other things a lot. But we get here that is a concept of patient of the center of care. This is actually emerged in the 19th century. And it's a very important concept. It is actually in accordance with the principle of medical ethics. So the concept of patient as the center of care strives to improve health care quality through integration, patient values, and the medical ethics. Then in 1985, Thomas Beauchamp and James Childress came up with the four principles of biomedical ethics. Which one is, first one is respect of autonomy, beneficence, it means do good for the patient, non-maleficence, this goes to Hippocrates, of course, non-maleficence, do no harm, and justice. And this is actually very famous principle of ethics. Then a few years later, another American group came with another 5 principles of ethics. Beneficence and non-maleficence, do good for the patient, do no harm, fidelity, responsibility, integrity, justice, respect the people's right and dignity. Then another group came up with another 7 principles, exactly repeating again. Non-maleficence, do no harm, beneficence, do good for the patient, health maximization, the benefit, efficacy, respect of autonomy, justice, proportionality. Then recently, another one came and said, only one principle, patient comes first. But this is this is just to tell you there is no certain consequences or there is no real general consequences about different type of principle. But all goes, actually, if you study all of them, they are focused around almost the same things. Then we came up in 2014 in that book with the principle, what we call value-based medicine. In values-based medicine, patient is the center of care. And whatever you do for the patient, what we call it action in normative ethics, knowledge as evidence-based medicine is integrated in it. The skills which you gain, the technology which you adopt should be all serving the patient. And all this will lead you to make a decision for the patient and the plan according to the patient condition, according to the circumstances, according to the patient culture, according to where you are and which patient you are dealing with. That is the frame, all this was within the frame of medical ethics and that is what we call values-based medicine. So value-based medicine is the concept to ensure that the principles of medical ethics is strictly implemented and observed in every step of patient management. Values-based medicine is in the integration of patient preferences into clinical practice. Values-based medicine has emerged in order to stress that medical practice is based on values as well as evidences. So that is that is, as we stated in the book, underlying every clinical case practice, there is value, and that is value-based medicine. Here we don't talk about value. In that book, we talked about value-based medicine. We changed it to values-based medicine because value, people thought it is value, it means money or the cost, and that is absolutely not what we mean. That is, we mean the values in the moral meaning. According to it, we have several principles. Autonomy, as it is in almost every type of ethical principle of ethics we discussed before. Beneficence is the same, do good for the patient. Non-maleficence, do no harm, justice. And we added, we emphasized about patient dignity and honesty as in applied ethics. So if we talk about each one of them, autonomy, what does it mean, autonomy? Patient has the right to refuse or choose the treatment. Patient has right, has to be accepted and respected. But this can be different. Culture, some cultures, the patient really doesn't want to make a decision. He leaves the decision for the doctors to do, or do for some reason. The social and family ties are different from culture to culture, from country to country, and even within the same culture, between family to family. Some families that some husbands, they cannot make a decision without wives, as a vice versa, but some people, they would like to make their own decision, regardless the opinion of the partner. Age, here comes a very big ethical dilemma we are talking about. What we call it pediatric patient as 18. But is the patient at 14 or 15 or 13 intelligent, has the right to decide for himself? If the parents, they don't agree about things like that, this is another ethical issue. Psychiatric patient, can they consent for themselves? Do they have also rights? Should be respected. But who is going to consent for them? How can you really, consent is not only a signature. The last thing in consent is the signature. Consent is the understanding of the patient to the problem and the agreement of the patient to certain process or certain procedure to be inflicted on him. That is the real meaning of consent. Facing this, when the patient is dying for reason, do you think that the patient is capable, psychologically capable to make a decision? In that condition, who is going to decide, patient capable or not capable? So a lot of things really is rather than it's simple autonomy, patient right, but there are ethical issues in every part of it. One of the things like that, patient-doctor relationship or physician-patient-family complex relationship, as we call it. It is not a simple relationship. It should be direct between the doctors and the patient. But in fact, it's not direct in most of the cases. Patient make a decision with consultation with the family, with other people, and the doctor has the right actually and has the duty to consider the family in it. In pediatric patient, you cannot go to the pediatric patient to take a consent or agreement without going through the family. In simple way, patient has certain rights, should be respected. Among this, patient has the right to be treated and to have good treatment. And the patient has the right to be partner in making decision and the right to refuse or accept the treatment. He has to consent for every step of the treatment. Understand it before signing it. Confidentiality, privacy, dignity. Also, he has to be educated. He has the right to be educated to know which disease he has. What are the consequences? What are the complications of such a disease? And the patient has the right to complain. He has the right to sue the doctor. He has the right to complain if he finds any deficient in the treatment. Doctors, our duty, respect patient right. We have to be honest to the patient. We have to do what the best for the patient. We have to be available for discussion. We have to stay current to improve our knowledge, our skills in order to provide the best treatment. We have to train residents. We have to get people trained to continue the service. We have to do research and find treatment for untreated problems now. And we have to work in team and respect the working environment. Second principle, beneficence, it means do good for the patient or best interest for the patient. To do good for patient and patient interest must be the main or solo goal for everyone dealing with patient. It is our obligation and our duties as a healthcare profession to promote the healthcare and the welfare for every patient. And we have, at the same time, again, honoring and strictly respecting patient personal autonomy. Third principle is what we call non-maleficence. First, do no harm. It goes, of course, to Hippocrates, as we said. But it is not simple as it looks. First of all, what is harm? Surgery itself is harm. Is it the expected or not expected complication? Is it the clinical worsening or deterioration? Is it the harm? Is it the error or mistakes which may happen? Is it the negligence of the patient? Or it is a violation of her patient right? Or maybe all of this. So in this, if we can come with something out of this, that is in every step in the treatment or making a decision, we have to guarantee the patient's safety. But even this also has ethical problem. What about first operation, which all of us did? Is this the best treatment for patient when I operate the first operation? So there is guideline. Everyone cannot be a big professor or big doctor unless he starts with the first operation. So there is ethical guideline, as clinical guideline, as practical guideline to do the first operation, and in the same time you guarantee the patient's safety. New technology for the first time used, new drug for the first time used, also should be in mind, patient safety comes first. Actually, as we said, do no harm and do good for the patient are traditionally, for thousands of years, are the basis or the main principle of bioethics. But there are, as we said, from ethical point of view, if you read the books about written by philosophers or bioethicists, you will find different perspective and different understand. But in our neurosurgeons, in our books in which we wrote, we try to make it practical. So to be applied, to be implemented. And the patient has to understand this, has to understand really what could be good for him and what could be bad for him. Justice, this is a big problem. Medical ethics and human rights. The right to have access to medical facilities and effectively treated is one of the basic and fundamental human rights. It is actually in the first chapter of the human right, which was written or produced by the United Nations. But justice has conflicts and dilemma as well. Socio-health economy, cost availability, cost and the availability in every place. Not every place has gamma knife, for example. Expensive drugs, how can be used, and the other things can be available to everyone or no, rather than, and the waiting list itself, something simple is not cost, the waiting list. Which patient should wait, which patient come first? And this is also a justice problem. And there is a thing which coming now, with a variety of hospitals and a variety of different types of treatment. Do we treat patient as they need, or treat patient as they deserve, or they think they deserve? They ask for extra service. So what is the obligation of the doctor or the neurosurgeon in this? You should treat the patient as needed medically, or as he asked for an extra service. I think the answer, it looks simple, that as needed first, but also there's nothing wrong if you can provide extra service. Here comes just another example about global ethics and global justice. Aristotle said, we are required to treat similar cases alike. This is more than 2,400 years ago. Do we do that? For example, this is 3 children almost the same age, all have hydrocephalus, all have the same disease. One treated properly, had a good life, and that is good, and we should do that for everyone. One partially treated, he is also survived, but the other one who couldn't find a good treatment and he has lost his life. What about him? So the problem with justice as a principle of ethics, it has to be redefined really. The modern medicine is advancing very rapidly and it became very costly. The new technology often overwhelms resources. It is necessary to use cost-benefit ratio analysis to determine where benefit comes and where do no harm begins. Is that principle ethical? If we go to virtue ethics, the branch of ethics, it is not. But practically, we have to accept it. So that is the modern ethics. There are something called modern ethics, which is coming in. But how to make it ethical? This is important. When we take it out of personalization of the patient, we do it for a patient, whatever he is, whatever comes from, because that is what we have, and do our best as much as we can. Fifth one is the dignity. I believe that's why we added different than the 4 principles of Beauchamp. That is, dignity is, I believe, is the central to ethical medical practice. Preserving patients' dignity is not only basic human right, but also important to ensure that patient will follow medical instruction and enabling the best outcome for his course of management. As we see it in every day, if really you have a good relation with the patient and the patient trusts you, he will follow your orders. If you lose that trust, the patient will never listen to you. He may harm himself, he doesn't follow your orders, but that is one of the principles that we have to think about. Dignity should be spelled out clearly to avoid any ambiguous or vague application or understanding amongst the hospital staff. Dignity is concerned with how people feel, think, behave in relation to the worth value of themselves and others. To treat someone with dignity is to treat them as being of worth in a way that is respectable, respect their values and individuals. Last one is the honesty. Trustfulness and honesty, in which the relationship, you cannot build any relationship with anybody without honesty. So to build a good relationship with a patient, it must be based on honesty and telling the truth. And we have, if there is any mistake or anything happen or shortage or unavailability of medication or treatment, we have to be honest to say this. If we look for all these 6 principles as a superficial reading for it, can we see conflict between different principles of medical ethics or how to be avoided? Actually, there is no, if we look deeply, as if we consider patient is the center of care. So autonomy and doing patient right and do the best for the patient, it is important. But sometimes, as we are going to see in results, if the patient, you advise the patient to have a surgery, needed surgery, patient refuse. How you deal with that? And also between do no harm and do the best for the patient, there are also a lot of superficial conflict. But really they are complementary to each other. As research, starting new medication, starting first operation, starting, for example, new procedure. Justice and beneficence, as we discussed it before. We cannot, discuss the issue of value-based medicine without talking about evidence-based medicine. Evidence-based medicine is one of the important signs and achievement in the modern medicine. But there are some ethical issues related to evidence-based medicine. First of all, how evidence is an evidence. we are mainly concentrating in evidence on clinical research and certain type of double-blind studies as the best studies, but still question how evidence is and evidence is still valid. And then comes to what we call it therapeutic equipoise, the balance between ethical basis of clinical research. Then another thing about inherited problem of large data. When you have any large data in statistic, the people who are mathematicians, they know that there are certain problems there. And the randomizing study, as we said about before, for which evidence. But if we look for the root or the key component of evidence-based medicine, there are three. Research-based evidence, second, clinician accumulated experience, knowledge, and skill, and the third one, which we don't talk about it a lot, patient values and preference. These are the three components of evidence-based medicine. This is which makes evidence-based medicine very important for our practice these days. Based on these three components, we come to the level 1, level 2, level 3, or 4. But the three components has to be there. Research-based evidence, clinician accumulation experience, and the patient values and the principles. Goes to the values-based medicine, we find evidence-based medicine is a part of it as well. And actually, in that book, which I showed in the beginning, Bioethic, Neurology, Psychiatry, Genetic, and Open Access, in the chapter which I wrote, in the abstract, we insisted there is no conflict between evidence-based medicine and values-based medicine. And even in the conclusion, we repeated again, value-based medicine and evidence-based medicine are and should be integrated, complementary to each other, and not conflicting at all. Just to run through a few cases which all of us see every day, just to show you how the ethics are implemented or the dilemma of ethics we live in it. Severe head trauma, the favorite topic of my dear friend Franco. He's one of really great people, from ethical, from values, and also neurosurgery. When you what is the real indication for it? And what is the outcome? Should you consider the outcome as one of the item for indications? Should family participate in the decision to perform surgery or no? And this comes the culture, the background, and the area. So there's no one answer in it. Second question. Patient says, 63-year-old, you saw such kind of patient, healthy, never been admitted to hospital, back pain, start limping, did an MRI, find metastasis everywhere and large tumor. Suggest surgery, patient refused surgery. And the patient is still walking. Would you wait till the patient became paraplegic and urinary incontinent, sphincter incontinent, or you start persuade him to be operated? So questions come. Why do some patients refuse treatment? Is it patient problem, refusal treatment? Is it a patient problem, or it is the doctor's problem? Or is the approach to the patient is the problem? So we shouldn't give up from the beginning, patient refused surgery, okay, so signs that he refused treatment, and that is no. Should be analyzed, should know why the patient refused treatment. Maybe he doesn't understand it. Maybe it was presented to him in the wrong way. So things like that should be considered. What should be ethically done to work for the patient? As we said, do good for the patient. People here, very often we see it in hospital, waiver the patient right for confidentiality. If, for example, that patient, one of his relatives, we say, okay, I would like to convince the patient to be operated, so I will tell his cousin, tell someone to come to help us to convince. Many doctors, they say it is okay to do that. But in fact, it's still waiver of patient right of confidentiality. Shouldn't be done without patient permission. Case 3. This is very sticky one. Patient operated for microdiscectomy, very common, nice operation, improved after 1.5 years, came back with pain. That is the disc removed. This is post-operative adhesions, no disc, diagnosed as some people call filled back surgery syndrome. Studies about filled back surgery. Is this terminology, filled back surgery syndrome, ethical? Does any patient likes to know that is the name of his disease, that my previous operation is failed? Why there is no hepatic surgery syndrome, failed hepatic surgery syndrome, or failed cardiac surgery syndrome, or failed renal surgery syndrome? I think this is very unethical terminology and should be omitted completely from our dictionary. And the story about it is a long story about it, but maybe another time we can talk about it. Last case I am going through to it also about talking about patient rights and the autonomy. This is a child came to us also. He has brain stem cavernoma. He was unconscious. He was in serious condition. We offered surgery. The father was very hesitant. And of course, was aware he has so many questions. One of the questions many of the neurosurgeons, they don't like. But the father has all the right to ask, can you do this surgery? If there is any other place can do this surgery better than you can do, if there is other facilities or another instrument or equipment may help, it's not available with you, available to, you should not, we should not be at any or by any means angry or upset by this question. Patient has the right to ask any question, and we have to answer any question. And the consent has to be informed consent. All the complication has to be stated clearly, and he understands clearly every kind of complication and signed on it. So my conclusion is, ethics is a complex field. Over thousands of years, humans have yet to develop an ethical theory to satisfactorily handle all issues of healthcare. Medical ethics, although general universal, are interpreted differently in different places. Values are also relative, so that value-based medicine is subject to the relativity of religious beliefs, culture, milieu, politics, law, geographic, and others. There is clearly ethical relativism in that what is considered morally accepted by certain people, it can be completely unacceptable by others. This is all right. There's no problem with that. It doesn't matter which type of ethics theory, 4 principles, 6 principles, 7 principles, 1 principle. The most important thing is that we have to understand and digest and believe in it. Patient is the sole center of care. That is the main aim, regardless which kind of theory of ethics or principle of ethics you are going to follow, because all of them focusing on this. There is a great need, actually, to include values-based medicine and bioethics and medical ethics in every neurosurgical and medical and surgical training programs. Not only in the postgraduate training program, but also we believe bioethics should be part of every curriculum for all medical schools. Thank you very much.
Thank you for your exhaustive presentation, and I will add for discussion some issue. One issue is the global care. There is no way in which we can think that a neurosurgeon who is in the middle of an African country can have the same facilities that we have and can treat the patient in the same way. The big mistake that we have done with evidence-based medicine, it's believe that we can apply it everywhere. We have published a recent paper reviewing the number of randomized clinical trials published. Only one in 7 is done in low and low middle income countries. 6 out of 7 are done in high income countries. Therefore, the result of the randomized clinical trials cannot be applied everywhere. I give you an example. The rescue ICP, the randomized trial on decompressive craniectomy, about 3/4 of the patients were done either in UK or in Italy, where medicine is free and rehabilitation is free. The best result of the surgical arm decompression are reached after 12 months from injury, meaning the patient has to be treated in rehabilitation for 12 months, 1 year. How many countries can treat the patient for 1 year? How many countries will supply the family, the money, the support, economical, and so on? So it's extremely important to understand that evidence-based medicine is just based on randomized clinical trials who are done in one part of the world, not in the other. So applying the whole thing to all over the world may cause extreme problems. So what I suggest is that we go out of the evidence-based and we create a format where we privilege consensus conferences, where since the consensus conference has a format where you can invite experts from all over the world and discuss with the expert which possibility of treatment you have in different countries. The other thing I wanted to tell you, it's the concept of good outcome. What is a good outcome? Ahmed touched the point. Do a patient who is not independent outside home and partially dependent at home has a good outcome? Question mark. This makes a tremendous difference, because if this patient has a good outcome, many surgical trials are positive. If the same patient has a bad outcome, all these trials fail. So we have to consider that the definition of good is not equal to everyone. And the third and last point is the COVID teaching. COVID teaching, it's something that we learned even ethically, from the ethical point of view. For instance, in many countries, like my country, where we had the big heat of the COVID wave, we almost closed all hospitals and to treat a very huge number of patients. Therefore, neurosurgery was reduced, and the neurosurgeon had to find a way to continue to treat emergency. And we postponed most of our surgery. Postponing neuro-oncology was a problem. When we recalled the spinal patients, the degenerative spinal disease, almost half of them didn't come to the hospital. So where we write in the indication for surgery, since most of these patients were cured just waiting for the COVID, this is one issue that you don't find in paper. You find a lot of papers saying we reschedule surgery. The reality is that when we started rescheduling surgery, and we have done from May, now we are operating full time, many patients with spine disease didn't come anymore. They were almost good. So how do we realize that these were the right indication? And the other big ethical teaching in the COVID is we neurosurgeon, we think we are apart. We are extremely advanced. We have a lot of technology. We are different from other doctors. Maybe we are better than other doctors, we think. In front of the pandemic, we realized that we are like the others. And many of us were involved in the cure of patients that they have never seen. And they were good. We did a good job. We reconvert many of us to ICU, to pneumology, to infective disease. We were able to deal and to be equal to other colleagues. And this is another ethical. The ethical teaching is you have to think that first you are a doctor, then you are an neurosurgeon, not the other way around. And if you are a doctor, you have to take care of the patient who need care in that moment, not abstract definition of patient. So I just wanted to stimulate the discussion and remember to all of you, in these difficult times, neurosurgeons have shown that they can work, they can survive, and they can be helpful to the society. Thank you.
Thank you. Thank you very much, Professor Viday, for these wonderful pearls of wisdom, and also Professor Ammar for this excellent lecture. I'll just open the polls for our audience just to know how much did they grasp from this lecture. I hope the polls work. This is a polls which has 3 questions, and each one of you have to select one best answer. We would like to ask a question that do you think ethics is an important part of neurosurgical curriculum? And if yes, why? You may please send in your answers to acnswebinars@gmail.com in less than 10 sentences. We'll just open the topic for discussion among the audiences. So before that, I'll just share the answers. What is medical ethics? The poll has been answered by 76% of the voters, and the answer is the first one. It is the study of moral aspects of a doctor's personal life. Unfortunately, only 35% have answered it correctly. The most important consideration regarding information in informed consent, that is the second question. Almost 78% people have answered it correctly. That is, it must be understood by the patient. And the third is autonomy is best defined as. So it is, answer is self-governance. Nearly 57% have answered. So there is there is so much interest in your topic, Professor Ammar. Now I'll open the topic for discussion. May I please invite Professor S.N. Mathuria to say his comments.
As it has already been told that Professor William Osler wrote that the great physician and the good physician is that who treats the disease, and the great physician who treats the patient. Neurosurgeons are not only good physicians, they are good and great. So they have to treat the patient, not only the disease. And as far as the ethics is concerned, it is, say, medical ethics or neurosurgical ethics, most of the time do not vary, except that it will vary as per the financial constraints and the availability of the facilities at a particular place. This consists of philosophy, moral values, religion, and the humanitarian ground. And then, say, our responsibility is that either I do the best or I should get the best done by somebody else at the correct possible time with the correct possible means, which I think that is correct. Because the patient has entrusted all the responsibility in you. That's what is my feeling. The people may disagree to what I am telling. Like in emergency decision, sometimes the patient refuses. Patient has got a large brain tumor. He is going to cone. He refuses. Compressive lesion in the dorsal spine, as you have already shown, he refuses. If he refuses, we should try to get somebody who can convince him, which may be a social leader, it could be his relation, or it could be some religious leader who can convince him. If he is unable to do so, I think that there should be a governance which should say that the neurosurgical, opinion is above the opinion of the patient. How it can be done, I don't know. That we have to see. Say about the research and all. See, obviously, once the patient is supreme, the research, treatment, everything, for everything, the patient is supreme.
Thank you very much, Professor.
Thank you.
Professor Hideto Kimura.
So thank you for your excellent presentation and this moment and wonderful lectures. So I'm so impressed your lectures. So of course, the patient is always should be center of the care, and I totally agree with your opinions. Your lecture. We have to have the good relation to the patient. We have to always be trusted by the patient, and of course, I know the patient can reject the surgery, best surgery, from our doctor's opinion. If the patient is suffering the multiple metastasis for the whole body. So finally, we have to think about what treatment can be finally cause to the patient happiness. So also, we always thinking about what is important. We, as a neurosurgeon, we have to choose the treatment for the patient happiness. So medical ethics is very important problem. And also, I agree to the included in the medical curriculum in the medical student. Thank you for your nice lecture.
Thank you.
Thank you, Professor Kimura. Yes, my co-host, Dr. Liu.
Hello, Prof. Ammar. Thanks for a very informative talk. I have 4 questions to ask Professor. One is about the declaration of the surgical result. I think recent years in United Kingdom, there is rules to ask surgeons to declare the result of their surgery, which I find is good. But again, because of that, I personally feel that most surgeons will try to avoid doing complex and complicated, and also those with severity and poor result cases. So what do you think, Prof, in terms of ethically? We can declare and see who are the best surgeon when the family come and ask us who are the best surgeon in the town. So based on whatever declaration by surgeons in your country or in your town, you can actually identify, because there are many instances that somebody in your country may have over promoting themselves only within your specialty, but the patient outside will not be able to know. So which one is more ethical is to declare all your result, where some patient may not be get treated because of some surgeon may want to keep a good track record, do not want to operate a complex cases, and is it ethically right for the patient who demands such surgery? There was one question. You want to answer first, Prof, or you want to listen to the other?
Well, good. Answer this first.
Yes, okay.
Well, thank you for the questions. It's a very intelligent question. Well, first of all, that is, if we remember our guidance, patient is the center of care, and yes, whatever we do for the patient. Yes. Second principle, we have to see what is value. Value is valued as which patient value. Yes. So what if I make a decision for a certain operation patient needs in one country, that is maybe the patient will be paralyzed, for example, after surgery, hemiplegic or something. And if some cultures, they can accept it and they say no wrong with that. So yes, I can go for that. But if this other countries, they said, no, I don't want to be operated if I am going to be paralyzed. This is, so you have to follow, but you have to offer honestly your opinion, your suggestion, very honestly, the percentage of this and this, and let the patient be your partner in making a decision. This is one thing. The second question, the second part is very important. If it is a complex surgery, and I don't have all the equipment for that procedure, or the skill in that procedure, I have to be honest. This is the sixth principle, honesty. I have to tell the patient there is possibility to be operated. Maybe you have better result, but not in my hands, in another place. And I guide him to another place. And I help him to go to that place. I think this is the answer for your questions.
Thank you, Prof. I have 2 more questions, Prof. I totally agree with Prof that skill and knowledge are very important for all surgeons. However, in terms of technology, I have some doubt. I attended many webinars. Some good surgeon or super surgeon may think that we have actually over promoting technology, overuse technology. Some surgeon would think that certain technology may not be required. But again, most of us are average neurosurgeon. So I would want to get opinion from Professor. How do we adapt technology according to our level, and how do we not to be influenced by market force, because every technology that we use may incur additional costs to the treatment, Prof?
This is a very, very important question. And this is a dilemma where we are.
Yes.
Because that's, for example, the marketing of different instrument, equipment based, and try to everyone to sell. This is different. Again, I am as a surgeon or a trainee or even a professor, so I am required to learn, to gain skills every day, to get knowledge every day as possible. In the same time, if there is any technology available, and the technology, it's neurosurgery today, not like 20 years ago. The navigation, the gamma knives, the other things. We have to adapt these things for the benefit of the patient.
Yes.
But there is another question coming up now, and actually that was supposed to be a meeting, the first meeting in the United States, but canceled because of COVID. What we call it, the ethics of robots. That was the title of that meeting. It's a closed group meeting. If, for example, you are using very high tech or robotic surgery, and something goes wrong to the patient, who is responsible? Who is accountable? The one who made the technology? Or the one who sells the technology? Or the one who uses the technology? Or all of them?
Yeah.
We are coming to the era. Actually, we have to face it. For the first time, that's why the value of clinicians, surgeons, or medical physicians to come into the field of ethics. Before, the philosopher used to follow what is happening. Now we try to be one step ahead, one step ahead what's happening. So we cannot stop the technology. The opposite, we have to encourage the technology, but we have to put the technology on the right track to follow the ethics and to be very clear who is accountable, who is responsible, who will get the benefit. That is very important ethical question. And actually there are now a group formed that is because the term became the ethics of technology or the ethics of computer. And that first meeting, which was unfortunately canceled, I hope you will schedule, ethics of robots.
Yeah, thank you, Prof. Last two questions, Prof. We were bombarded with the term evidence-based medicine in the 80s. Now we go to value-based medicine, Prof. So, and what value-based medicine to a government is different for a value-based medicine to a patient. Quote example, for a government, there's a limited budget. So value-based medicine for a government is to treat more patients with limited budget. So you tend to choose a technology that are cheaper. But for patient value-based medicine, it's the best for the individual. So which one is more ethically correct, Prof?
Sorry, I have to say hello to you. I have to go operating.
Okay. Thank you very much, Frank.
Go ahead, and congratulations for a very good seminar. See you soon.
Thank you, Professor. Thank you for coming.
It will be a good sign that everything is okay for all of us. Thank you.
Just so honored to have you, Professor. Thank you very much. Right.
Actually, that is why, as I told you, that's why that is first in the book. You will see that we called about value-based medicine, which we changed it later to be values-based medicine. Value first, that was the problem of care. That is talk about the cost, talk about the money, talk about resources, about the government. But that is not what we meant. This is, yes, the justice in distributions, the facilities. This is one of the principles of ethics, the justice. And this is, yes, this is the duty of the government. And the healthcare stakeholders. That is how justified way or ethical way or justice way to distribute the healthcare facilities to cover the majority of the people. That is duty of them. But values which we mean, this is part of it. Values which we mean, again, if you look for that, our drawing, patient is the center of care. Our values are serving patient values. Our duties serving patient needs. Our job is to help the patient. So that is which make difference. Evidence-based medicine, in that respect, is integrated in values-based medicine.
Prof, my last question, if you allow, this is something that we always face is when we're going to do a surgery with a shared responsibility, we're doing with our juniors. So may I ask that in what ethical value that we need to observe when we do the sharing responsibility, and should this be part of the informed consent? Thank you, Prof.
Yes, this is a very important question, and that's what we call it, that is first surgery. Everyone has to go for the first surgery. Not only has to go, it is our duty to teach resident to operate and be a good surgeon and even be better than us. This is one of our duties. But there are not, this should be done on the expenses of the patient. Patient has to know that the surgeon will be this Mr. So and so, but I will be there and I must be there, watching him, taking him step by step. We all of you, good neurosurgeon, you know, we know our people. One is good in that, one is not good in that, so gives piece by piece. We should not throw the resident alone in the operating room with big cases and we say, go and do it. And this is the best way of training. Let him struggle with the patient. But this is not right, because this is within the cost of the patient. Our duty to teach the resident to learn, but not on the expenses of the patient. We have to be there. We have to be scrapped, and the patient has to know who is operating on him.
Thank you very much, Professor.
Thank you, Lou, for asking. And now I think if there are no more questions, then we can wind up this session. I would like to thank Professor Ahmed Ammar for introducing us to this very novel topic for us for the first time, that is ethics in neurosurgical practice. We learned a lot from you. On behalf of the Education Committee of the ACNS and the President, Professor Yoko Kato, I sincerely thank you for sparing your time for the education of the residents and young neurosurgeons. Thank you very much. So until next Saturday, it is bye-bye from us.